and good morning to everyone. Thank you for joining us for PerfWeb's special series on autologous blood salvage and transfusion management. This program is brought to you through a very generous, unrestricted educational grant by the Humanetics Corporation, and we want to thank them very much for that. I think you're really going to enjoy the program today, and so without too much further ado, I'm going to introduce our faculty. To my immediate right here in the studio is my dear friend and somebody who I have learned to not only respect and love and admire, but somebody who has truly been a mentor to me, though at times we disagree, though very rarely, but when we do disagree, we really do disagree. Dr. Hany Samir. Dr. Samir is an assistant professor of cardiac surgery, critical care, transplant quality, assistant professor of clinical anesthesiology in neurosurgery at the DeBakey Heart and Vascular Institute or Center, Houston Methodist Hospital, telehealth HS Consulting. You're the director of that program, and you are at the Houston, the Texas Medical Center in beautiful Houston. In fact, that's what we're looking at in the backdrop back here. That when you look at the Texas Medical Center, it looks like it's the city, and then you see Houston, the city. It's almost the medical center almost dwarfs it. Yeah. Largest medical center in the world.
Absolutely.
1 and 2 combined doesn't even match to it. So that's here with me, and then coming to us from Germany is Dr. Patrick Maybaum. If we can show Dr. Maybaum, please. Dr. Maybaum is the professor and director of the Department of Anesthesiology, University Hospital, Würzburg, Germany. He has published more than 200 journal articles and reviews in the area of patient blood management and intensive care medicine. And though Dr. Maybaum is new to me and my relationship with him, I've truly enjoyed the time that I've spent speaking with him, and he passionately feels very strongly about transfusion management and reducing the need for allogeneic blood transfusions in the patient population that we generally deal with. So I think both have some excellent presentations, and I think Dr. Maybaum, you're actually first, again, coming to us from Germany. And by the way, this is our morning session, so we're going to have an afternoon session, which is also going to be live, and doing this to accommodate our European colleagues and also our American or Central Time Zone colleagues, United States, Canada, and South America, Mexico, so forth. So Dr. Maybaum, I think we have your slides queued up, and we're really ready to go to you. So thank you for your gracious time being here with us today, and the floor is yours, sir.
Okay, hello to everybody. Good morning or good afternoon. I'm Patrick Maybaum. I'm working as an anesthetist. Moved to University Hospital Würzburg a couple of months ago, and before I worked at the University Hospital in Frankfurt. So I'm going to talk about cell salvage, and in the second part I'm going to talk about the role of cell salvage in patient blood management. So next slide, please. So, I mean, we have a lot of situations where we see blood loss. Here's a patient in cardiac surgery, and the next picture shows a patient after trauma, and the next one shows a picture of major vascular surgery. And on the next picture you see that in some of these patients we are able to collect blood, to collect round blood, and this should be an option to save patients' own blood, to keep an eye on patients' own blood, and to think about how we could reuse and retransfuse patients' own blood to avoid any unnecessary allogeneic blood transfusion. So if you go to the next slide, you see that in most of hospitals and in most of countries, physicians are mostly thinking about allogeneic blood transfusion from donors. So in any situation, in any time where we see major blood loss, the first reflex and the first step is often to think about allogeneic blood transfusion. And I'm going to talk about risks and benefits, and I'm talking about alternatives. And on the next slide, you can see that we really observe a huge variation in different types of surgical procedures. And here you see data from cardiac surgery. On the y-axis, the percentage of transfusion rate. And a lot of hospitals are doing the same surgical procedure. Here you see isolated CABG surgery, but the observed transfusion rate is different, and there are some hospitals with about 20% transfusion rate, but there are also hospitals with more than 80% transfusion rate. There you see a high variation, differences in cultures, differences in probably behavior. And on the next slide, you see that the same is true for orthopedic surgery. Here you see data from Austria for knee and hip replacement. And again, there are some hospitals who are able to do surgery with less or without any allogenic blood transfusion, and other hospitals, number 10 or number 14, they use blood transfusion in almost every patient. And on the next slide, I've summarized all the side effects and risk factors and adverse effects in the terms of red blood cell transfusion. And we know from a lot of studies that allogenic blood transfusion are associated with an increased risk of mortality. Blood transfusion may be associated with increased risk of morbidity, of ischemia, of infection. We see from time to time patients with transfusion reactions, and of course, any RBC unit is associated with increased costs. And on the next slide, you see a summary from the Nature journal, who stated that saving any blood unit results in saving lives. So it's not blood transfusion that saves lives. This is true in some cases, but in the opposite, if we as a population, as physicians, if we are able to save blood transfusion, we might even also save lives. And on the next slide, you see the techniques or principle of the retransfusion system. So in any patient with major surgery, and the surgeon and the anesthetist, they should think about if we can collect wound blood, if you can collect the blood of the patient. If this is the case, then we need to heteronize this blood, and we can collect patient's own blood in a reservoir. And then in the next step, in the next slide, you see that if you are able to prepare and if you are able to wash the collected blood in a reservoir, and there are different machines on the market, then we will receive a RBC concentrate unit. And what you can see on the next slide is that after washing, after preparation, the hematocrit increased from about 15% up to 70%, and the quality of the blood, of the washed red blood cell unit concentrate, is really similar to allogenic blood transfusion. So, and this is the patient's own blood that we can use for retransfusion. And on the next slide, you see some markers and indicators that we measured in terms of the quality of cell salvage. And what you can see here is data from a Frankfurt study in terms of cardiac surgery, orthopedic surgery, where you see collecting patients' own blood result in a hematocrit of about 10 to 15%. And this can be determined in a lab, in a central lab, or this can also be measured by a machine, here using the CAT-SMART machine. And on the next step, you can see that after washing the collected blood, you receive really high hematocrit of about 70 to 80%. And again, this was measured in the central lab, displayed by blue column, or even by the machine. So using a cell salvage device, you are able to use patients' own blood, and you can increase hematocrit, and you will receive a red blood cell concentrate. And on the next slide, you can even see that we measured elimination and removal and washout of some other factors. And again, potassium, protein, heparin, free hemoglobin, white blood count, platelets, all these cells and factors and issues could be eliminated and could be removed by cell salvage. And on the next slide, I summarize the typical indications. So cell salvage is indicated in major orthopedic surgery, particularly in joint replacement, spinal replacement. It's indicated in major vascular surgery, in cardiac surgery, in liver transplantation, and trauma. So you can see a lot of medical indications, medical surgical procedure that are really feasible to use to implement cell salvage devices. And in the next slide, I can show you some data from our team where we analyzed research data and we looked at the published trials, and then we summarized. We have done a meta-analysis, and what you can see on the next slide that we put together all the published trials, and we found that using cell salvage, you have really a large clinical benefit. You have less patients with allogeneic red blood cell unit transfusion. And the next slide, you see less RBC units per patient. And on the next, you see less infection. So next step, please. Less infection. So if you use cell salvage system, you might really reduce unnecessary red blood cell transfusion, and you are able to reduce red blood cell units per patient, and you might even have a benefit in infection and morbidity. And on the next slide, you can see that there are really a lot of studies focusing on cost effectiveness, and summarizing all these studies, you see on the next slide that cell salvage is really cost effective, at least in the amount of 1 mature red blood units. So for the first step, thank you very much for listening, and now I think that we will move to Dr. Samir.
Excellent. Okay, Dr. Maibaum, that was all excellent data. I've got 7 key point questions already that I'm going to be wanting to discuss with you. So Dr. Samir, I think we have your slides teed up and ready to go.
Okay.
Yeah?
Thank you, Joe. Thank you, everyone, for having me here. I really appreciate the opportunity to share some of my experience. And I'm just going to look at the agenda here, and generally, Dr. Maibaum really covered a lot of things. I'm going to cover some of the things I've been working on. And I mean, what's cell salvage? All of us know what cell salvage is.
Yes. Could you excuse me 1 second? Hey, David, for some reason, I don't see Dr. Maibaum's video anymore. Is there something we need to do to fix that? There we go. I see it now. Excellent. Thank you. Dr. Samir, please forgive me.
Okay, no problem, sir. Okay. So all of us know what cell salvage is. I'm going to just go quickly the definitions. It's collecting blood from the field or from whatever open wound is. I'm going to say it from the field of open wound because I applied that to the ICU. And then either process it or giving the blood back without processing it. And we're going to talk about that a little. And advantages, we have it all. All of us know. I mean, obviously, avoid blood transfusion, avoiding risk of infection. Certain populations that we work with in the U.S., like Jehovah's Witness, will not take allogenic blood transfusion. They would definitely refuse that, but will take cell saver. If it's a continuous cell saver circuits, we're going to talk about that. Now, lucky for me, I work in a big Jehovah's Witness center, and I'm going to go over Jehovah's Witness religion with some of our European colleagues are not familiar with it. It's a certain religion that avoids taking blood transfusions. Whenever we operate on them, we have to have a long discussion. Do we take albumin, platelets, FFP? And some of them will not take blood, but will take platelets, will take cryo, will take artificial products. So really, every one of them is very different, and we have to talk to a priest. We're a big center because we want to take care of them. And there's one statement I'll make, and it's not a controversial statement. They will refuse blood, but they will accept organs. Whether that's, I mean, sometimes doesn't make sense to some people, but that's reality we have to work with. And we do organ transplants on them. We're going to talk about that. So we have to talk with them, see what they take and not take. We have a checklist. We're going to go over that. And we have a special consent. Even the consent you're going to see has blood and a line through it. So it's impaired. Those patients, there's no choice. We have to use aggressive cell salvage. With some of them, we do normal volumic hemodilution. We didn't talk about it a little. which is take the blood from the patient, replace it with saline up to a certain hemoglobin, and you take the blood out, keep it on a scale so it doesn't clot off. And here's one of the cases we've done. It was our first double lung transplant on a JW patient. And as you see, the consent, blood with a line through it. Okay, this is one of our surgeons who's an amazing surgeon, does all the transplants on JW patients. Right now, unfortunately, he's not with us in Houston. He's in Montefiore, Dr. Shinen. I got permission from him and from the patient to show this picture. Just this is some of the setups we use to collect the blood. So basically, what we do is the patients, we're collecting the blood from the patient, and we have a line, a big bore line with a peripheral 14 gauge or a MAC into the patient, and the blood goes directly from the cell saver to the reservoir and back to the patient. No discontinuation. Okay? So that's the key issue, is it has to be continuous. And they are very important to them. So continuous access to the blood. The blood cannot leave their body. So when we have it from the patient, from the field, go into the line, to the reservoir and back to the patient, with no stopping. Whether we wash or not is a whole other story. And I just want to illustrate the picture to show basically the diagram that we do. And we follow that diagram, I have to tell you. And clinical benefits we all know: reducing hemolysis, high hematocrit, reduce transfusion risk, improve the outcome. Now we're going to talk about there's some studies, and I was amazed that Landau's study was only 2 years ago. This was the first data on continuous autotransfusion. And that for me is amazing. It was 2 cohorts, ortho and cardiac surgery, which really were using cell salvage most of the time. And the endpoints were red cell separation performance and washout quality. Okay. And inclusion was greater than 18 years of age, elective orthopedic or cardiac surgery, expected blood loss greater than 10% of body volume. That was the inclusion for the study. But the 10%, I'm going to talk about it later. Exclusion is pregnancy. I'm going to talk about that later too, because things change as we move along in life. So the target is hematocrit between 55 and 75, or PRC concentrated hematocrit 55 and 75. And washout creatinine, potassium, albumin, heparin, free hemoglobin, white blood cell, and platelets. Joe, remind me about the heparin thing. I'm going to ask you a question later when we get to the discussion part.
Yes, sir.
Okay. And here the hematocrit was the value is 12, median 10 to 14. And that's from the cell salvage. From the lab was 14. They measured in the cell salvage and in the lab to compare. And there was really the p-value was very comparative. So there was no much different. PRBC, the concentrate 78.5, 73.7, with the variation 71 to 73, 67, 75, and the p-value was comparative. Not much difference. So really the lab enforced the fact that the cell salvage measurement by Cat Smart was accurate. And here's the washout for the K. Again, the median was 92.5, the minimum is 73.3, the max 99.1. You see, for me, the K is important. Again, the slide Dr. Maybaum showed, but I'm not going to go over it for the sake of time. So obviously, the results showed that red cell separation performance and washout quality were very comparative for each other. I would confirm that with the lab. Now, for me, cell salvage starts before going to the OR. Get the patient's hemoglobin up, and that's what we do with JW patients. Erythropoietin, iron supplementation, and that's important pre. And then sometimes some of the patients will come and donate their own blood before. That's if they have high hematocrits. Normal volemic hemodilution. But I have to tell you, normal volemic hemodilution is not easy to do if you don't know how to do it. You have to do it every day. And basically, what we're doing is taking patient's blood out, replacing it with saline or albumin, whatever you want to do. One other thing we'll talk about, which is not approved in the US yet, and I'm sure I'm going to pick out Joe later, the infusible oxygen-carrying fluids. Unfortunately, they have not gained approval yet. The military is working on it, I'm sure once the military goes for it, then we're going to be approved by the FDA. So cell salvage is safe. It's a resource serve for getting blood. Some people might not agree. They say, oh, you know something, you're spending money getting cell salvage set up. I feel like we have it available in the hospital. Use it. It's relatively inexpensive. And here's cell salvage. Indications: anticipated blood loss greater than 20%. For me, if you feel like you're going to need it, you should use it. And you have to have experience with your surgeon and your operation. All of us have been in situations. I've never regretted not having cell salvage. I have regretted not having cell salvage set up. I've not regretted, oh, I set it up and we wasted it. I just have to tell you, this is blood. For me, wasting patient's blood, throwing in the garbage is a big deal. So you have to keep in mind, there's a lot of patients besides JW that want to get blood. Is blood safe? Yes, but a lot of patients don't want to get blood. I think we have a little.
We have a little bit of time.
Yes.
You blazed through all of that, but that's good because I think there's going to be some tremendous talking points here. So, welcome back. They were great lectures, but go ahead. I'm sorry.
I'm sorry. So just one slide. So if you're thinking, should I salvage or not salvage, you should always salvage, okay? Because hesitating is not a good idea. I think we're missing some slides.
You're missing some slides?
Yes.
But you're using your computer, see?
No, but the slides, I mean, I think it's something. Okay.
Wait, there you go. Okay, so backtrack. So we have a little more time.
Yes.
You're going too fast.
No, well, because I want to get to this last slide. It's very important to me.
Okay.
So we're post-op use. Okay. Let me tell you, this is something we developed. I know it's not in the literature. We developed with the collaboration with Dr. Lobi, one of our amazing surgeons who's now in Jackson. Okay. We developed for any cardiac surgery redo cases, open heart or lung transplant. We take the patients to the ICU, and we're not closing the chest. Patients in the ICU, we warm them up, get bleeding under control, and all of us have been in this situation. So we developed setting cell salvage bedside and collecting every 500 and giving it back. People in the beginning, you're crazy, what are you doing that for? For me, it was just criminal to throw the blood in the garbage. I don't want my blood to go to the garbage. If this is my blood, please save it and give it back to me. So we developed that, and really has worked very well in saving our blood transfusions and preventing tamponade. We suction all this blood out, we don't let it accumulate there and soak the drapes, and soak the vial drape, and cause the tamponade, and give it back to the patient. And I'll tell you, that helped a lot. And we take the patient back to the ward to wash, clean up, and set up. So I'll tell you, our department now sets cell salvage in the ICU all the time. And really, you just put the suction catheters there and hook it up, and just collect every 500 and give it back. Obviously, with that situation, we do not wash, and we'll talk about the no washing situation. And that's another question: should we wash or not wash? We were just talking about this before the start of the program. I think you should wash, yes, but if you're bleeding at a very high rate, don't think about washing. Just giving it back. Just give back to the patient. Don't stop. No stopping. No, don't go to A, B, or C. So I'll tell you, really, I think it's very important that we think about the ICU. That's a huge saving of blood. And I'll tell you, we gave a lot of blood. The patients have done very well. The only thing, you have to measure your ACT very frequently, because you are giving heparinized blood, and you have to keep up with your protamine. So that's something, it needs experience. It needs a dedicated cell salvage tech who is aware of the situation, and the nurse has to be always correct the coagulopathy that's going on. And if the bleeding goes on for a while, you have to correct your platelets and all the coags. So as much blood as you're giving back is good, but again, you have to keep up with everything else. And one thing we do also, which I haven't mentioned before to Joe, because I wanted to surprise him here, whenever we take ECMO circuits apart, I don't want to throw anything in the garbage. I want to collect all this blood and take it back into the reservoir, clean it, and give it back to the patient. No blood should go to the garbage ever, 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 ever. It makes me very bad. I don't want my blood to go to the garbage. It hurts me. So I do feel, why not collect all this blood, process it, and give it back? And I think, now just the final thoughts. And again, please, if you think should I salvage or not do it, don't hesitate.
Excellent.
Thank
Thank you very much. Very passionate, I believe, which you always are, and I'm glad you feel this way. Can you, let's see, you need to unspotlight us. We're going to go to discussion. I'm sorry? I didn't understand. Uh-huh. Is next. Oh, so he has another lecture. Okay, forgive me. Okay, so Dr. Maybaum, I'm sorry. I have the organization of this all messed up. So now we're going to tee up Dr. Maybaum's second set of slides. And Dr. Maybaum, welcome back. And the floor is once again yours.
Okay, so thanks a lot for coming back. Now I'm going to talk about the impact of cell salvage and blood transfusion in the context of patient blood management. And according to the current COVID-19 pandemic, we see a lot of news released in terms of blood shortages. And here you see, and on the next picture and the next after one, a lot of press releases with the same message. We have a blood shortage, we have too less donors, and we have really a problem to have blood units for our patients and to guarantee elective surgical procedures. So again, alternatives, including cell salvage, is really much important to reduce unnecessary allogeneic red blood cell transfusion. And on the next slide, you see data from 2 German university hospitals. And on the next figure, you see the numbers of surgical procedures, and they went down in March and April on the upper part. But on the lower part, you see that the number of blood transfusion is roughly the same because of the COVID-19 patients. So on the next slide, you see that if you even have a decrease of surgical procedures and a decrease of cross-matching for elective surgical procedures, the consumption of red blood cell units is still high to be provided to intensive care patients and to COVID-19 patients. So on the next slide, you see roughly some articles focusing on patient blood management during the COVID-19 pandemic, and cell salvage really an important issue and plays an important role in this context. And on the next slide, you see that the WHO has already recommended and suggested that blood sparing techniques should be implemented to improve patient care outcome and to reduce costs. And what you can see on the next slide is that really roughly a lot of countries have already launched and published national guidelines in terms of patient blood management in the United States, in UK, in Australia, and on the next step you even see a picture from the European Union. They are saying that patient blood management, including cell salvage, should be the standard to avoid unnecessary blood transfusion. And on the next slide, you see the main principles of patient blood management. We are focusing on pre-op anemia management, and the main part is minimizing blood loss and minimizing bleeding. And we have different techniques. We are focusing on coagulation management, but we are also focusing on intraoperative blood salvage, and of course on the third pillar on the blood unit and rational use. And on the next slide, you see the guidelines from the United Kingdom. And what you can see in the next is that really there are different recommendations. And if you go from step to step, then you see, just move forward. You see if you have patients with an increased likelihood of blood transfusion of donor blood, then you should use cell salvage, or even in patients where you are afraid of post-operative anemia, this is an indication to use cell salvage. And the next you see that cell salvage should be available 24 hours, and on the next you see that cell salvage should be used in any patients where you have blood loss of 500 milliliters or higher, or more than 10% of calculated total blood volume. In the next step you see that cell salvage is also indicated in patients undergoing cancer surgery if you talk to the patient before surgery and if you get the consent of the patient. And of course, cell salvage might be considered in women undergoing cesarean section if you have patients with a high risk of hemorrhage or anticipated bleeding during surgery. So really broad consent of guidelines published in the UK that will help you to implement cell salvage in your hospital, in your country. And on the next slide, you see, again, when we are talking about the patient blood management program, you see on the left side, these are different items, but cell salvage included in the blood sparing techniques will result. And if you are able to implement these measures, then you can reduce need for transfusion. You will have less complication. And these are data from 4 German university hospitals. But on the next slide, you also see data from Australia. And where you can see in the next step that the implementation of really a patient blood management bundle, including anemia management, coagulation management, minimizing blood loss, but again cell salvage, then you will see on the next step that this bundle implementation will reduce blood transfusion need, will reduce mortality, and of course will reduce costs for the hospital and the society. And on the next slide, you see that if you put together all the data that have been published in terms of patient blood management, including cell salvage, and we found 17 studies worldwide, then we found, and that you can see on the next slide, that patient blood management is able to decrease transfusion rate, is able to decrease major complication, and is even able to reduce mortality. And if you go to the next slide, next please, next, then here again you see some recommendations and tools to use to implement and to improve implementation in hospitals, here provided by the United Kingdom Cell Salvage Action Group. Here you can find a lot of information, how to use cell salvage, what is important, what should be afraid of, what might be some side effects, how you can teach your people, your colleagues, etc. Thank you very much.
Excellent, Dr. Maibaum, excellent. Okay, so now I think we unspotlight us, and then when there's Dr. Maibaum. Dr. Maibaum, can you tell us a little something about that picture behind you, if you don't mind?
Yes, this is a picture of our wine region in Würzburg. So yeah, I'm really happy to show you our countryside, and yeah, people enjoy to walk around and to drink some wine and to enjoy life.
Well, I think we'll take that as an invitation, and Dr. Samir and I and Jennifer and Magic and David should be there in the next few days. We just need a flight.
Yeah, of course. You invited, huh?
We'll look forward to it.
If you find a flight that brings you to Germany, no problem.
Absolutely. I bet we could find one. You know, I have a small plane. We would all fit in it. I would have to go the long way around over Greenland and Iceland, eventually make it there. Might take us a while, but I would get there eventually. With that said, I do have a couple of comments that I'd like to make, and that is that it seems interesting to me that we are all still sitting here talking about cell salvage, autotransfusion, transfusion management. I like to call it transfusion management versus blood conservation. I don't like the term conservation. It sounds like you're trying to withhold something from somebody. So, but all these years later, we're still having this discussion. And I'd like to understand maybe a little bit about why, Dr. Maibaum, you feel that may be the case, if it is, in Europe. And then Dr. Samir, if you could add in why you feel that is something that you're seeing here in the United States. Nope, what happened? Oh, technology glitch. Hold on. We're good? It doesn't look good. There you go. Okay, so Dr. Maibaum, you want to field that one first?
So what is the question?
So the question is, you know, why are we still having this discussion that so many people don't use autotransfusion for some reason, and I can't understand it this many years later.
Yeah. So this is a really good question. So from my personal point of view, It is more easy to ask for an allogenic blood transfusion, to pay less money for an allogenic blood transfusion, to transfuse allogenic blood transfusion, instead of asking perfusionists, asking colleagues or nurses to prepare cell salvage device, to collect blood, to put together heparin, to think about is it worse, is it not worse, and to keep an eye on quality measurements. And probably this is an issue, at least in our country. It's cheaper to use the donor blood than the patient's own blood. And this is one of the main topics that we are working on to inform patients, to inform colleagues, physicians, that from our point of view, it's unethical to use donor blood instead of patient's own blood just because of costs or workload.
I think that's a reasonable answer. Dr. Samir, what's your perspective on that?
Well, my perspective is a little bit, I have to tell you, I look at some realities that I deal with every day. The peripheral hospitals, Joe, are not going to have available cell salvage techniques in the middle of the night. You know that. They have an emergency FEMPOP and emergency AAA. To call the cell saver team in, it's not the easiest thing for them. So they will just go with that. Some of the nurses will set up the cell saver, but the tech is not there to wash and process. So they have to wait for the cell saver team to come in, and so it's easy just use blood, have blood available. It's not an excuse, but that's reality that you have to deal with. So I have to tell you that unfortunately is part of the realities. The hospital will have like perfusion available, cell saver available on call, and how long they're going to come into the hospital, that's again the realities. The major institutions, no problem. The smaller institutions, going to be a problem. You know that.
Well,
that's just the care, the periphery versus central.
May I disagree with you?
Yeah, absolutely you may.
Okay, I have to disagree with you on that. And Dr. Maibaum, I'd like your thoughts on this, and I want to hear your thoughts on this as well, Dr. Samir. So in our practice, because we have a very, very robust autotransfusion program, so our group does in excess of 3,000 cases a year in multiple different hospitals. And what we understand is what you just said, that if the technology is not available, readily, immediately available, then it doesn't benefit the patient. So we spend a lot of energy and effort to train the nurses on collection only, safe, effective collection for the patient, so that when a patient hits the hospital with, let's say, a ruptured femoral graft, and they're really bleeding, and they rush, or even a ruptured AAA, and they go straight to the operating theater, and they're already calling people, so our autotransfusionist is already on their way. The machine is set up and ready to go in a collect-only status. The nurse can hand the line to the surgeon, plugs the heparin in, begins the process of anticoagulating the blood and collecting it, and then the autotransfusionist or perfusionist, whatever the case may be, arrives, the technologist arrives to manage the operation of the machine. And we have found that to be highly effective at increasing the utilization of autotransfusion, but really more importantly, the whole reason we're all here, I find that it has been tremendously beneficial to the patients that we're caring for, and the hospital satisfaction, the surgeon satisfaction, and ultimately the patient satisfaction scores go way up when we do it that way. So you're correct in that the peripheral community hospitals, unless they invest in the time, and it's not money, it's time, to do this properly, then you're right. It's not going to get used. But if you do invest the time and and you are dedicated to it, I think it can work very effectively. That's my thoughts. Your thoughts?
The problem is I see all sides, and it's time and money. I have to tell you that. It's time and money.
Well, we can discuss money, but Dr. Maibaum, what do you think of our idea, the way we manage community-based hospitals that don't have 24/7 in-house either autotransfusionists or perfusionists. I don't hear Dr. Maybaum. Oh, you're Dr. Maybaum. You're muted.
Yeah, I'm sorry.
There you go.
In our hospital, in our country, most of hospitals, they are teaching anesthetists or anesthetic nurses, and the anesthetic team is responsible for working with the cell salvage device. And we put a lot of effort to teach our colleagues, and as soon as we have an anesthetist 24 hours in a hospital, so that's not a big issue to provide cell salvage support 24 hours.
I agree with that 100%. And you know, Dr. Samir, I feel it's the same thing with ECMO. I feel that you have to have ECMO specialists who are readily available, because you're right, in some of these community-based hospitals, it's very difficult to get a perfusionist to the ICU. Now, ultimately, they need to be involved, but we have to broaden, I think, the types of people who are educated in this technology. And I think that a lot of physicians, anesthesiologists, as well as surgeons, need to be better informed about it. But I do want to sort of follow up on cost. And before I do, Jennifer, do we have any questions? We do? So why don't we do this? Oh, you have a question? Okay. So you go ahead, and then we're going to go to your
Dr.
questions.
Maybaum, I have a question for you. This is an interesting thought. Came up at my pool last weekend. One of my friends is an OB-GYN attending, and she's on the editorial board of the OB-GYN journal for here in the U.S., and she has an abstract submitted about using cell salvage for vaginal delivery. Should we approve the abstract or not? I'm putting you on the spot right now.
So that's, I mean, the answer depends on the country where you live. At least in my country, it's not allowed to use cell salvage in these type of procedures. And I know that this is really restrictive, and other countries are more liberal in this field, and probably you should teach the team, you should know about potential side effects, and you should have at least a second suction system where you can decide if you have a bleeding, then of course you use cell salvage, collecting blood before you waste the blood, and if you have some fluids that from the woman or around this procedure, then you should use the second suction system. So you should accept.
Okay, thank you. I will give her that advice. The second question I have for you is about the meta-analysis. I read your meta-analysis very well, and I have a question. One thing, it did not show reduction in mortality. Why didn't you see reduction in mortality, you think?
I mean, cell salvage is really a single intervention, and we know from any other medical drugs or medical intervention that it's really difficult to reduce mortality based on a single intervention. And that's why it's so important to include cell salvage in the patient blood management program as a part of a multimodal program. And just if you use cell salvage, and if you can reduce the amount of red blood cell transfusion, I mean, there's no interaction that by reducing red blood cell transfusion, you even reduce mortality. So on the way to die on an intensive care unit, a lot of things are happening, and it's not just the one or two red blood cell units that makes a difference.
Thank you.
Mm-hmm. Very good. Jennifer, you have some questions. You have a microphone there. You're welcome to ask them. Mm-hmm. Is Jennifer on?
Pretty close. Okay. Is that better? All right, very good. So just as a reminder, if you do have questions, go ahead and write them in the Q&A section on the Zoom. Professor Maybaum has done a nice job of starting to answer those. We'll go through some of them live. If we can't get through all of them today, we'll definitely follow up with you regarding some of the most key questions you're asking. Okay, so I'm going to take us back to the topic of ECMO. So Dr. Samir, you mentioned the use with ECMO patients. Are you actually bringing the cell salvage device to the floor? That's question one. And when do you transfer to the cell salvage device? That's question 2. And what are the main concerns or obstacles when performing this procedure?
Once the patient comes to the ICU with an open chest, we bring the salvage right at bedside, and we hook up we have like either the suction catheters or NG tubes hooked up to the chest. Basically, we call it with jerry rig it. That's an expression we use in the U.S. We have the 2 suction catheters laying on the chest, or a big hard suction into the chest, and it's collecting into the patient. And again, every 500 we wash and transfuse back, measuring ACT the whole time, correcting protamine. And the biggest obstacle is resistance and lack of familiarity. We've never done this before. Dr. Maybam and I'm sure I've gone through a lot of people say we've never done this before, we should not do it again. Lucky for me, Dr. Lobi, who is from Germany also, he is very progressive, and we said we need to do this, and we've been doing it, and everybody found that we're saving patients' blood, we're not throwing it in the garbage. And that was like a bigger thing. And we just have it plain like that. See, look at all this blood could have gone to the garbage. And just being very graphic with the staff, they appreciate what we're doing. And the blood bank also, the head of the blood bank was very involved, and he's an amazing person. And he actually helped us get this going. After that, we did it a couple of times, and there was no resistance anymore.
Very good.
Thank you. Okay, here's our next question. And we'll go ahead and have Professor Maybam answer this first, and then we'll turn over to Dr. Samir, see if you guys both align on the response. What do you consider the most important quality measurements for your QC program? Potassium, hematocrit, or free hemoglobin? Professor Maybam, you go first.
Yeah. So it depends on the target endpoint. So if you have a look if this machine does what it should do, so if the target is to produce a red blood cell concentrate of the patient's own blood, then I would focus on the hematocrit. And that's why I showed data that hematocrit should increase from about 15, from 20, up to 60 or 70 or 80%. So this is one important indicator in terms of quality of the device. To answer the question, does this device is doing that it should do? And the second perspective is if this device can remove or eliminate all the other issues that we do not want to have in the back. And here we can look at removal of potassium or free hemoglobin or protein or whatever that you can measure in your lab or what is easy to measure.
For me, hematocrit is the most important. And for academic reasons, I suggest everyone when they collect, blood, send a tube to the blood bank so you get a hematocrit, and you'll be really impressed, with the difference in hematocrit is and how, what you can do. And obviously, we can even concentrate the blood more and more and more. And sometimes I ask for ultra concentration as much as we can. I don't really worry about the potassium that much because there's so many variables that affect that. So the potassium I'm not really worried about. I just worry about I want the high hematocrit.
May I interject?
Absolutely, sir.
So, I think that I think that's one of the questions that I'd like to quickly ask, and that is, of course, for me, potassium is very, very important. Washout of the heparin is very important. Of course, I view autotransfusion as not only removing those things, you're getting concentrated red blood cells back. You are losing the plasma, but you're also losing for allogeneic blood transfusions, the high cytokine load, the high potassium load. But there's still a lot of people who do not believe that you remove all of the heparin and that you remove all of the red blood cell ghosts, we'll say, the plasma-free hemoglobin, and of course the potassium, which is going to be very, very high. So Dr. Maybam, I'll start with you, and then Dr. Samir. How do we address this when people are still convinced that the blood you're giving back may be causing the patient to become anticoagulated? I find that to be odd, but it is something that I have dealt with. What say you?
The problem is, as soon as you have really major bleeding with 2, 3, or 4 liters of blood, and as soon as you use cell salvage, there's no need to use allogenic blood transfusion or red blood cell unit. So you are thinking about retransfusion and you feel a bit safe. But if you have a bleeding with 3 or 4 liters, you also lose coagulation factors and all of these other issues that need to be substituted too. So that's the issue, that a lot of people think that if you're using cell salvage, that cell salvage is associated with coagulopathy. But that's not the case. The cell salvage device is producing a red blood cell concentrate, and that's it. And if you have a patient with major blood loss, you need also to think about coagulation factors, platelets, and all these other issues.
Dr. Samir?
I agree 100%. And when anybody says that, say, okay, that's fine. We're going to correct the coags because the bleeding is what causes the coagulopathy. But to be honest with you, it's an academic discussion at this point. You think it causes coagulopathy, that's fine. We'll correct all the coags, we'll measure ACT and everything. But I mean, I really don't have to get hung on this, Joe. I mean, for me, they all know that the bleeding is causing the coagulopathy. So I just tell them, no problem. We'll just transfuse back, we'll take care of everything as is. For me, I don't harp on the point. For me, that's just, I'm getting a source of blood that's consistent and high hematocrit. And as long as they're convinced with that, I'm okay.
Yeah, and I'm not talking about massive bleeding. I'm talking about just a let's say a total hip that might lose 400, 500, 600, 700 cc's. There are people who actually believe that it will anticoagulate the patient by giving that autotransfusion blood back. And it is something that I think there needs to be stronger education in understanding what the end product is that we're giving back, which is red blood cells and a saline base. That's it.
I think there's a big deficit of knowledge about cell salvage, to be honest with you.
And I think it's underutilized.
Absolutely.
Jennifer, you had another question? I'm sorry, ma'am.
There were a couple questions around. Yep, there are definitely some questions around sort of both the panelists' perspective on complications. So thank you very much for covering that. If there are follow-up questions regarding complications with the use of cell salvage, please ask for further clarification. So we'll go on to the next question, which is what are the panelists' view on using, thank you, lipid and leukocyte filters for cell salvage blood?
Dr. Samir, you're first.
To be honest with you, I think we use filters on all our transfusions, so I think that's standard for us.
What about leukocyte reducing filters? Do you think that's necessary with autotransfusion blood?
I don't think it's necessary now, but it is part of our setup. So it is. It is what it is.
No, I think we usually use just a Paul blood filter, but the leukocyte reducing filters, it's just so hard to push the blood through them.
No, it is.
Do you use them regularly?
Yes, we use them regularly.
For autotransfusion blood?
Yeah, yes, sir.
Interesting. Dr. Maybaum?
Yeah, and now in routine cases, we do not use any additional filter. But I know literature and published studies that are using leukocyte depletion filters in patients undergoing cancer surgery or obstetric or cesarean section. But I know from experimental setting that using a leukocyte depletion filter before retransfusion, it takes time and blood flow is reduced, and you need to know how to handle this device and how to include this in the retransfusion set. And in a routine case or in cardiac surgery and trauma and vascular surgery, from my point of view, and as far as I know, international guidelines, there's no need to use the filter.
Okay.
Jennifer?
Very good. Okay, so this question is regarding the use of autotransfusion with Jehovah's Witness patients. And so, Dr. Samir, we'll start with you on this.
Which patients, I'm sorry?
Jehovah's Witness.
Okay.
What are your thoughts on washing with a 3/4 full bowl for a Jehovah's Witness patient? as washing a full bowl is always recommended to remove contaminants. So the question is, what are your thoughts? Is a partial bowl versus using a full bowl for Jehovah's Witness patients?
I mean, for a Jehovah's Witness patient, I'll tell you, my recommendation in the beginning, to be honest with you, depends how much bleeding you're going through. So, I mean, if you only have like 3/4 of a bowl and you're done with the case, yes, you should wash and proceed. I mean, would not waste one cell in a Jehovah's Witness patient. Every cell needs to go back, okay? So, and you have to talk to the patient also beforehand, because some patients will not accept washing. They're very knowledgeable about this whole situation. So you need to talk to the patient and make sure they're okay with washing. Because some of them feel washing separates the blood. So I have to tell you, you should not waste one blood cell. Even if you have, people tell me sometimes we have 100 cc. I obviously at 100 cc, give it back. But I mean, if you have less than a bowl, then I would definitely wash, if the patient is okay with it. And this has to all the discussions beforehand in the pre-op holding area.
Dr. Maybaum? Oh, you're muted, Dr. Maybaum. You're muted, Dr. Maybaum.
What is the main question?
So let me give you the hypothetical. You know, the Latham bowl technology, unlike the other, I forgot the different types of technologies there are, but the Latham bowl technology allows for multiple different size bowls. You're doing a Jehovah's Witness case. They set up a 225 cc bowl. The patient only bled enough to have a red cell volume that will give you, let's say, 2/3 of a bowl of a 225 bowl. And so you have 2/3 of a bowl, so a partial bowl. Would you wash that and give that blood back to the Jehovah's Witness patient or any patient, or would you abandon it and just go ahead and discard it?
Okay. I would use and retransfuse every drop of patient's own blood.
Mm-hmm. Agreed. Whether it's Jehovah's Witness or not.
Yeah.
I agree with you, 100%.
Okay. All right. Next question. Does anyone do quality assurance measurements of intraoperative cell salvage devices? And if there are parameters that you have as a standard that you would not transfuse the collected blood? And this person says, I am thinking particularly of cases of renal failure related to free hemoglobin. What parameters do you measure? So do we want to start with
Good.
Professor Maybaum
We
first?
could start with Professor Maybaum, certainly.
Okay.
Yeah, so again, this is a question regarding quality and what is the parameter, the indicator,
Yes.
is that right?
Are there specific parameters that if you saw them, you would not transfuse the blood? And then this person went on to further ask, this is specific especially in renal failure cases related to free hemoglobin. What parameters do you measure?
Probably this is a more theoretical question. So, I mean, in a patient with major bleeding, you have an increased risk of renal failure independent of cell salvage. Risk of renal failure is even increased regarding the number of allogenic blood transfusion units. So as soon as we know from experimental studies that cell salvage washing will reduce free hemoglobin, and as we saw this in our data and other studies show that the removal of potassium and free hemoglobin is working, I would not care about a small amount of free hemoglobin. I mean, even in patients with allogenic blood transfusion, we have free hemoglobin because allogenic blood transfusion from donors have storage lesions and potassium increase and all these other issues. So it's really difficult to put a relation between cell salvage, quality of cell salvage, removal of free hemoglobin, and any complications in the long-term follow-up.
Mm-hmm. Very good. I agree with that completely. And you know, in regards to, you're absolutely right, Dr. Maybaum. In regards to plasma-free hemoglobin levels, the potassium levels, they're quite high in allogeneic blood transfusions, especially when they've been sitting on the shelf for 15, 20, 30, up to 42 days. And you know, I have to take a lot of lessons from our pediatric colleagues that will not use blood that is more than probably 4 days old. And if you look at red blood cells, we didn't even touch on this, red blood cells lose their elasticity tremendously when they sit in a bag on a shelf in a refrigerator, whereas autotransfused blood, that blood has been demonstrated over and over again to maintain all of its elasticity. So, you know, we know the potassium and the cytokine load and all of that stuff is washed out, but most pediatric guys I know and gals will wash even their allogeneic transfusions before they give it to their young patients. And so I wonder if we shouldn't be taking those lessons. I know it's a controversial topic, but something that I think we should be considering.
Okay.
Jennifer, I'm sorry.
Nope, very good. Okay, we have just a couple more. So I know you talked a bit about washing versus unwashing, Dr. Samir, so we'll go there. In a severe trauma case, do you suggest that we do not wash the blood volume?
Actually, I insist that you do not wash the blood volume. I mean, if you're filling your bowl and you have no time, just give it back, and then we'll deal with the fallout of the coagulopathy and the potassium later. If you're, like Dr. Maybam said, if you're bleeding that fast, you need to give the blood back and do not wash. And not just severe trauma, cardiac surgery. I mean, you open let's say we redo chest, you open the chest. Instead, you open the ventricle. Instead of opening the chest, you are going to have to give this blood back immediately.
Okay.
So I would insist not to wash, to be honest, not just suggest. And I know it's a strong statement.
Okay. So one more question then, tied to with more into the OB/GYN realm. So are you still recommending double suction and double filter when there's, say, postpartum hemorrhage to decrease the risk of amniotic fluid embolism?
I have to tell you, that's what I was going to Dr. Maybam's opinion, and I think that's what needs to be happening. There's a lot of particulate happening, whether it's C-section or vaginal delivery, and you don't want this particulate flying. So you have to have two suckers on the field, to be honest with you. One the cell saver suction and one the regular suction that goes to the wall. Okay, so yes. Yes, I think you definitely need to have that. And especially if we're going to go, and that friend of mine, she's involved in she's a high-risk OB attending. She's going to do, and there's big issues happening with those deliveries. Yes, I think we should have two suctions on the field.
Okay, all right, next question, and maybe we'll go ahead and have Professor Maybam answer this one. And what types of procedures is the use of cell saver contraindicated? And someone did ask the question around cancer patients, so maybe you could give some clarification around what is truly a contraindication for the use of cell salvage. So Professor Maybam, if you could go ahead.
So cell salvage is absolutely contraindicated in patients with abdominal infection, so in gastrointestinal leakage, stool, or any type of infected fluid in the body. And then it depends on the country and on the national regulations and guidelines and suggestions. So there are countries, for example Germany, where cancer surgery is contraindicated if you not use radiation, just because of the theoretical risk of tumor cells and what. There is an ongoing discussion in cesarean section if you not use a second suction system, so in terms of amnion fluids. And but if you're talking about absolute contraindication, then I would argue with the infection situation, so bacterial infection of fluids.
Okay, very good. All right, so we'll go ahead and we'll go to the next question, and this is the question is regarding some evidence around the use of autotransfusion, and is there anything published that states that it reduces post-operative stay and overall hospital stay?
I'm not familiar with a post-operative stay and hospital stay.
Okay, very good. Professor Maybom, on your end, is there any data out there that you're aware of? Can you hear that? Professor
I
Maybom?
mean, if
Go
you,
ahead.
and this is a question that is similar to one of the previous questions, the cell salvage device is produced to improve cell recovery and to produce a red blood cell concentrate. And thereby you can reduce allogenic blood transfusion. And that it. And I would not focus on any clinical endpoint and hospital length of stay and mortality and 5 years survival rate or all these things. It's not produced for that. It's produced to save patients' own blood and to reduce unnecessary allogenic blood transfusion.
Okay, excellent. Thank you, Professor Maybom. Appreciate that. Okay, next question. So, Dr. Samir, we'll send this your way first. Do you routinely recommend the use of tranexamic acid with cell salvage?
It depends on the case, but for us, for cardiac surgery and for transplant, it's routine. Okay, so with other cell salvage procedures, I don't think so. But for cardiac surgery and transplant, it's routine for a lot of other reasons. So I'm not sure how you can extrapolate that to like regular cases. So.
Okay, very good. Okay, I could.
Yeah, from my point of view, those measures should be used independently. So the use of tranexamic acid is independent of cell salvage.
I agree with that.
Yes, you can definitely use both.
No, absolutely.
And I think it's, but Jennifer, if I may, so Dr. Maybom and Dr. Samir, can I ask Jennifer's the previous question from the participant a different way? Do you know of any studies, which I know the answer already is going to be what it is, that indicate or that demonstrate statistical significance in increasing length of stay when the patient needs to receive allogeneic blood transfusions? So same question asked a different way.
I have to say, Joe, that's an independent variable, because people get allogeneic blood transfusions for different reasons that are not related to there was no cell salvage. And there has been increased length of stay and increased morbidity from blood transfusion for sure. But it is an independent factor. I don't think you can correlate it with the cell salvage.
Fair enough. Dr. Maybom?
I mean, this is another topic, and this is still under discussion, and this is controversial, and I'm not quite sure. I mean, we have a lot of observational data showing that this is true, what you said. So the higher the amount of allogenic red blood cell units, the higher the risk of any complication and mortality. But in all the prospective randomized trials, this trend and this signal is not so clear, and probably it does not matter anyway. So probably you can use a lower hemoglobin level and you can tolerate lower hemoglobin levels, or you can even transfuse up to a hemoglobin of 12 or 13. Probably this is not a big issue for a patient, but you need to spend a lot of money to afford the transfusion. And as far as you have a problem with blood donations and blood shortage, from an ethical point of view, you should avoid any unnecessary blood transfusion.
Agreed. Well, from a cost perspective, which we haven't even really addressed, and both of you can just I'll try to do this very quickly, but I think that when I hear people say, well, we don't want to burden the expense of the cell saver autotransfusion, but when it's in collect only, the cost is really insignificant. However, even with the bowl setup, the processing, and so forth, if you just take the low end of a cost of blood, not the just acquisition cost, but the actual cost of transfusing that blood to a patient. So let's just use the lowest possible number and say it's $700, really low. It doesn't take a lot of, you do the math yourself, the cost of any one patient that ends up getting 3 or 4 or 5 or 6 units, or an autotransfusion case that bleeds 3 liters that you never gave an allogeneic transfusion to, you can pay for your service for an entire year of all the other patients. And if I can leave the hospital with a hemoglobin pretty much the same as when I entered the hospital, and I feel better, can breathe better, can move better, not short of breath, I don't feel tired, I'm going to be a lot happier than limping out of there with a hemoglobin of 7.1. So that's my view.
Actually, let me give you a little, I read on this yesterday when I'm preparing for our lecture. The cost of acquisition and delivery of 1 unit of PRBC in the US is $1,000.
Sure, fair enough. So there you go, $6,000. I can tell you what, I wish I could charge $6,000
No, it's
for a
1,000,
cell saver
1,000,
kit. Well,
1,000.
yeah, but if you give 6 units,
Yeah.
$6,000. I wish I could charge that much. Dr. Maybaum, your thoughts on the cost of blood? I know in Europe it may be a little bit different. Here in the United States, it's about $1,000, but it's costing somebody.
Yes and no. So cost of red blood cell units vary between 40 euros up to 500 or 1,000 euros.
Mm-hmm.
Depends on the country.
And is that acquisition cost or delivery cost? The cost.
No one knows the exact cost in terms, if you include donation programs and marketing and all these things, then you probably end up to several thousand euros.
Mm-hmm.
I know that we, as a society, we spend millions on euros to find the right blood donors.
Mm-hmm. Absolutely. Absolutely. It's a problem everywhere. You know, if you look at the number of units available in the National Blood Bank and the number of units that are transfused from the National Blood Bank, and that's here for the United States, and I think Europe has the same paradigm, the margin is very thin. If you have any mass casualty situation where you're having to use a lot of blood for multiple people, it can absolutely generate a situation where we don't have enough of it. And I think we need to get better at how we manage our resources, because it is not an unlimited resource by any stretch. Jennifer?
Okay, so I know we have about 2 minutes left.
2 minutes left. Okay.
Yep, so why don't we ask, there's a question here, some utilization questions. So one question is, what are your thoughts about swab washing? So
you mean you mean squeezing out the laps?
Yes,
Okay.
exactly.
So squeezing the laps out, like you're doing a case and you got the down in the belly or in the chest.
Why not?
Mm-hmm.
That's my answer. Why not?
Of course, I agree.
Get every cell out. I mean, I don't want to. Don't throw it in the garbage. Again, please don't throw my blood in the garbage. I'm going to make a T-shirt that says that. Don't throw my blood in the garbage.
Now and Dr. Maybaum, go ahead. Your thoughts on that, because I do have some quick thoughts on it myself.
Yes and no. I know some surgeons that are doing this, and they just use swabs and keep an eye on every cell. But I also know a lot of surgeons, they say it's too dramatic to the individual red blood cell, and so that's why they are not using, and they more keep an eye on suctioning. So yes and no.
So my thoughts on that are, and I've seen some of the best surgeons do this, and I've seen some of the worst surgeons do something else. You take the lap right out of the chest and you squeeze it into a bowl, and then you suck it out. Mm-hmm. That's terrible. How about taking a nice basin of saline, take the laps out, put them in there, let them soak, and let the cells sort of homogenize, suck that into the cell saver, because the cell saver is going to be very good at eliminating any of the lighter red cell ghosts, hemolyzed cells, fractured cells, whatever, and you're going to only give back those cells that have a reasonable viability in duration, at least a few days. of still good life within them. So that's my thoughts on how you manage saturated laps. Laps can hold a lot of blood.
Absolutely.
And,
They're designed for that.
Yes, and so I do think you should reclaim it, but I think you should reclaim it in a way that is commensurate with respecting the fragility. The durability, it's a dichotomy. The durability but fragility of a red blood cell. I think you just have to treat it with respect.
Okay, very good. All right, that's time.
We're done? We're out?
We don't have any time for questions now?
So we can do a couple more. The program officially goes for an hour and 15 minutes.
Okay.
So people are, they're hopping off as they
Okay.
choose. So if we like to go, it's really just a couple more.
I just have one question, Dr. Maybaum.
Okay, go ahead. Go right ahead.
Dr. Maybaum, what's your thoughts about the oxygen-carrying fluids available in Europe?
What do you mean?
The oxygen-carrying fluids, like all the salts that carry oxygen, instead of using blood.
Oxygen?
Artificial hemoglobin.
Artificial hemoglobin.
Artificial hemoglobin.
Yeah.
Yeah, now some experimental studies, but I'm not aware of any hospital or any physician in Europe that is using this artificial.
Do you think it's going to come to fruition?
It could become in 10 years or 20 years, I have no idea, but I think the nature is really complex, and a red blood cell is really, that's a wonder. So I'm not quite sure if we can do artificial oxygen carriers.
Mm-hmm.
Thank you.
What are your thoughts?
I hope it. I mean, I really believe in innovation, and I think it's going to happen. I think it's going to happen in Europe before the U.S. for sure.
Mm-hmm. I think so. Well, that's the case with almost everything.
Yeah.
I would agree with that. Okay, so before we just click off, Jennifer, would it be okay with you if I ask Dr. Maybaum to close us out with his final thoughts, and then Dr. Samir with his final thoughts, and then we'll let everybody know that we're going to be repeating the program live, not a rerun, but actually both gentlemen here to give another lecture, 3 lectures at 5 o'clock. So if we could do that, if that's okay with you?
Certainly, go right ahead.
So Dr. Maybaum, if you'd like to close this out from your perspective, then Dr. Samir, and then I'll let everybody know when we're coming back.
Yeah, so thank you very much for invitation. Thank you very much for organization. I really enjoyed to be a part of this lecture, of this webinar, and I really enjoyed all these more than 20 questions and comments and ideas. And so thank you very much to everybody for this nice evening from my perspective.
Thank you, sir. Dr. Samir?
Thank you. I really enjoyed, the most enjoyable part was the meeting Dr. Maybaum and the questions. I really enjoyed both, meet Dr. Maybaum and the questions. I like the interactive session. And again, if you just we have to be innovative, you have to put it out there, and you can be the first of doing something. Even if everybody else criticizes you, it's okay. It's okay to be out there. I learned that the hard way. So thank you, everybody, for joining us.
Thank you. And so everyone in the audience knows, of course, this program was approved for 1.2 Category 1 CEU by the ABCP. So if you need that certificate, please also don't forget, you have to go and click that QR code that was at the beginning of the program, and you can complete your evaluation. That's very important. We need to get that done. And you'll show it again. Yeah, we're going to show it to you again. And then we will see you at 5 o'clock, Dr. Maybaum. It'll be 11 o'clock, I think, at night for you. So we appreciate you being, that's hardcore when you do that. You obviously do anesthesia for cardiac surgery, or you wouldn't be doing that. If you were doing facelifts, I know you'd be in bed by 9. But 11 o'clock, you're probably just finishing dinner by then. So we appreciate you coming back at 11 p.m. Dr. Samir, we appreciate you hanging out and joining us again at 5 p.m. And the QR code is there. Yeah, there it is right there. So make sure you do that and complete that evaluation. Thank you, David. And we will see you all. You can come back to us now. And we will, there you go. And we will see you all at 5 p.m. Central U.S. time. So whatever time it is in Houston or Chicago, that time zone, we'll see you at 5 p.m. and you can figure out from there where you may be in the country or the world. See you then. Bye-bye.